hard act to follow you after such a talk. All right, so so I've chosen this topic on MR physics. Yes, I know that it's a bit dry topic, and so I've made it a little bit interesting by having both the clinical implications of what I'm going to talk about the physics. So why I chose MR was, well, MR is quite one of the most fascinating invention of the 20th century, according to me. And actually, if you see the physics of the MRI was actually borrowed from the astrophysics. And there has been over 90-year long history in the development of MRI, previously known as NMR. What happened was the physicists, like this is actually the gas cloud way far into the universe surrounding the galaxies. So these gas clouds, they do not emit light. So we can't observe it using the regular telescopes. But what the physicists understood was that the atoms, not only hydrogen, other atoms as well, when they are subjected to an electromagnetic radiation from that galaxy, the nuclei vibrate and they send out radio waves. And we can observe that, and thereby we can get images, pretty images like these. So then somebody had a brainwave, why don't we use that same to look into our body? And that's how we got the MRI. That is what we have today. And there have been 5 Nobel Prize winners in this field of MR, which is the highest in any imaging modality to have had medical Nobel Prize. And as we know, it's the most potent tool in our arsenal, and that's probably the apex of radiology. So why I chose MR angiogram today is, as you know, this year it's a vascular theme. So this fits aptly with the theme that we're going on to. And the other thing is, well, if you ask even the radiologists as to how the MRA signal is produced, I think most of us would say that, oh, it depends on the flow. When the spins go from caudal to cranial, they create the MRA signal. Well, it is true, but only partly true. It is an oversimplification of the process that's going on. Because if you argue in that way that if only the flows from foot to head creates the signal, as you can see, the arteries are quite tortuous. And my pointer is not working, but you can see the PCA, it's quite wavy. So if that were to hold true, then when it dips down, then we should have loss of signal, but that doesn't happen. So the physics is a lot more complicated than that. Let's just break it down. But for MR, to understand MRA, we need to first understand MRI physics. So I'll go through a quick rundown of the bare minimum requirements that we need to understand MRA. So first is the signal generation. How do we generate signals from MRI? As we know, the difference between hydrogen and a proton. Hydrogen atom has one proton inside its nucleus. It does not have a nucleon, a neutron, and the another electrons spinning around it. So the positive and negative, they cancel out each other. But when in the body, there are hydrogen ions, so the electron is kicked out, then we are left with a positive charged proton. That's what we call, also known as the spin, which we commonly refer to as. So this proton is not just simply sitting idle inside the nucleus. It is actually spinning on itself, rotating around itself. So when a positive charge or even a negative charge spins around itself, it creates a magnetic field around it. So this now behaves like a bar magnet. And like a bar magnet, it has a polarity, north and south, and a direction, what you call a magnetic moment. So it's pointed towards some direction. So in a resting state, as all of us are right now, these spins are pointing in all the directions. And the phase is not synchronous. It is like incoherent. So it doesn't create any signal. But once we put the protons inside a magnetic field, then they align. They align together with the magnetic field, just like bar magnets do when we place it in a magnetic field. Now, still they are in a resting state, a new resting state, which is aligned along the magnetic field. So now when we send in some energy, the energy is sent in the form of radio frequency wave. That's what we call the RF pulse. We push the spins from the perpendicular orientation into a transverse orientation. So this is kind of an excited state. So it cannot hold on to there longer. So the moment the RF pulse is switched off, it wants to come back to its default state, which is perpendicular. So, but it had received a lot of energy in going to the transverse magnetization or the transverse orientation. So when it comes back to its longitudinal orientation, it gives off the energy that it had acquired earlier. And we pick up that energy, and that's what is the MR signal that we are all wanting for from the patient. So next we talk about how contrast is being generated. So all the MR signal comes from the protons, but the protons, the signal varies slightly depending on its surrounding, which means if the hydrogen is in a fat molecule, it gives a slightly different signal. If it is in a water molecule, it gives slightly different signal. So let's break down what we just saw schematically into more mathematical form. So here we have in the first image, the blue arrow. So that's what the direction of the spin is at the resting state. And once we send the RF pulse, then it flips down to the transverse plane, perpendicular to it. That's the green arrow. So when we leave it long enough, after the RF pulse is switched off, the transverse magnetization slowly disappears and the longitudinal magnetization regains. And that's what we call as a longitudinal relaxation or a T1 relaxation. You can see in the bottom image that the blue arrow keeps growing with time. So this is one of the action that happens. There is another action that happens. So when we see the protons end on, initially the protons are pointing up, right? So after the 90-degree pulse, it flips into the perpendicular plane. It flips 90 degrees. But now this is a plane. This is not a single direction. It could be anywhere in the plane. It could be at 3 o'clock position or 6 o'clock position or 9 o'clock, anywhere it wants to be. But after the RF pulse, that's not the case. All of them point to the exact same direction. If it is 3 o'clock, all the protons are at 3 o'clock, and so on and so forth. So this also, after the RF pulse is switched off, they start to spread apart, what we technically call dephasing. And there are two reasons for it. One, the RF pulse was giving external energy to it, so keeping it under control. Now the energy is off, the external influence is off, so they start to drift apart. And the other is like these are all positive spins, so they can't, like poles repel, right? So they can't keep pointed at the same time, same direction forever. They start to repel each other. So this is what called internal effects or internal homogeneity, inhomogeneity. And this is also known as transverse relaxation or T2 relaxation. This image on the right, the bottom says the same. It's all pointed to the same direction. So the more familiar term medically, the T1 and T2, what we use day to day is actually a time constant. So when we saw the first phenomenon where the longitudinal relaxation first disappeared immediately after the RF pulse was given and then slowly crept back up. So that is how fast it comes up is what we measure as a T1. So the technical definition is when it reaches 63% of its longitudinal relaxation, then that's the T1 of that particular tissue. But for unofficial or practical purposes, we can just assume is that T1 is the time it takes for the longitudinal relaxation to recover. And T2 is for the transverse magnetization to disappear. Once they disperse, once they go out of phase, then the ones, let's say initially all of them are pointing towards 12 o'clock position. So now they start to dephase, and let's say some goes to 2 o'clock, and other to 10 o'clock, and some goes to 3 o'clock, and the other 9 o'clock. So now they are in opposite direction, so they'll cancel out each other. So the T2 signal will also drop with time, and that time constant is the T2 of that particular tissue. So how we differentiate between fat and water is, fat, it comes back to the longitudinal relaxation faster than water. In a similar way, fat dephases quicker than water. So which means that fat has a short T1 and T2, and water has a long T1 and T2. So a third topic to consider is the localization, which means like this is the gyromagnetic Larmor frequency that relates the frequency and the B0, which is the magnetic field. So basically the speed with which the proton spins is proportional to the strength of the magnetic field it is in. So if it is in a 1.5 Tesla, it spins at a speed. If it is 3, it will spin twice as fast as it was in 1.5 Tesla, because it's directly proportional. So let's assume here we put a patient inside a magnetic MRI machine. It's a 1.5 Tesla scanner. So now all the protons from his head to toe are processing at the same speed. or the same frequency because they are in 1.5 Tesla. Now let's add a gradient field, which means that in one end, the foot end, it has a negative magnetization, and then the head end, it has a positive magnetization, but only by a little bit. Here, it's just 0.1 Tesla higher or lower. So now we created a gradient field. At the foot, it's 1.4 because it's 1.5 minus 1, and it's at the head, it's 1.6 because it's addition of 0.1. So the frequency of the proton also changes simultaneously. If you assume that it's spinning at 64 megahertz at 1.5, it's 60 at the foot and 68 at the head. So why is this important? So when we send in the RF pulse, you can actually choose a frequency at which the pulse can go in. So if we send in a frequency between 64 and 65 hertz, it will stimulate the first slice, the slice number 1, that thick of a tissue, that thick of a slice. So if you want to do a much better spatial resolution, we want to reduce the thickness of the slice, then we just send in a little narrower bandwidth of the radio frequency pulse. So only a narrow slice of the body tissues are excited. The rest of the tissues are not excited. Then now we've got a tissue. So the tissue has, now we've got a slice. So the slice has an X plane and a X-axis and a Y-axis. So now we need to create differences between the voxels. So basically what we are trying to do is that all the spins are spinning at a unique frequency or a phase. I'll come to that in a short while. So now if you apply the same gradient in the slice that we have selected in the XY plane, the same happens. So let's say the right side of the body is spinning at a slightly higher frequency, which is 65 megahertz, and the left side of the body spins at a slightly lower frequency, which is 63 megahertz. And there is a gradation. So we have now split the slice into columns. So now we have to go on to another step to split the columns further so that each voxel becomes unique. And that we do by phase encoding. So in the first figure A, we can see that all are pointing in the same direction. So now we send another gradient field and switch it off immediately so that the spins, when they start to point in a different direction, they maintain the same direction. So in the C, what we have is that they are spinning at the same frequency, but they are pointing at different directions. So this is what we call difference in phase. So final thing looks like this. The slice, each proton, here it schematically represents each voxel, and the protons inside that voxel have a unique frequency and or phase. So it's almost like a hotel with a lot of floors and multiple rooms. So no two rooms can be same, right? It can be like the first floor, third room, or a second floor, third room, or it can be a second floor, third room, and a second floor, fourth room. So each has a unique address, and that's what we are trying to achieve by creating this phase encoding and frequency encoding. So when that particular protons in that particular voxel gives us a signal, we already figured out how to differentiate a fat proton from a water proton. And now we have further information to where to put that in the grid, in the matrix space, in the voxels that we have. So finally, we talk about the sequences, the gradient echo, spin echo sequences that we report on every day. So sequences are manipulations that we do so as to bring out some features from that particular tissue. So what I mean is that, let's consider this example. So this is just the same that I mentioned so far. The A on the frame 0, we have a longitudinal magnetization. We give the RF pulse, we tilt it to the transverse magnetization. So over time, it slowly starts to regain. And after the frame 4, we can see that probably 80% of the longitudinal magnetization has regained. So now if you send in another RF pulse of 90 degrees, only that 80% is going to flip into the perpendicular plane. It will be lesser than what it was to begin with. So because only what has recovered can go back. Not all the spins will go back. So in this example, like we saw that the T1 here was 63%. So if we send in the second RF pulse, only that 63% will flip. The rest won't. And we saw that the fat recovers quicker because it has a short T1, and the water recovers slower. So in this example, the proton B, that is from a water molecule. As you can see, that longitudinal magnetization is creeping up more slower than the first one. So by the time the second RF pulse comes, there is only lesser longitudinal magnetization from the water protons, and they're only going to produce lesser signal. So in this way, we can create more signal from the fat than water, what we more used to known as the T1 weighted imaging. So this is how we achieve it. So the blue line represents the water. So it goes slower because it has a longer T1 and T2. So next parameter is the time to echo. By the way, the time difference between the first RF pulse and second RF pulse is the time to repeat, or the TR. So shorter TR produces fat-based imaging, or a fat-weighted imaging, T1 weighted imaging. And now let's consider a second experiment where we only analyze the transverse magnetization. So I just told you that the spins start to dephase with time because of both the external factors and the internal factors. So now after a time point, let's send in a 180-degree pulse this time. So what it does is that it refocuses it, because it just flips the spins over, which were initially dephasing it. Now it will start to rephase. And at the point F, it will again reach back, but again, it will not be 100%. The reason because we can only adjust the external influence that we managed to do with the RF pulse. The internal influence will not be adjusted. And the internal influence depends on the proton, whether it's in the fat or in the water. So thereby we can again see we can use this as a tool to differentiate whether the signal is coming from proton in the water or in a fat. How we do it? We wait longer. So longer TE, the fat spins would have dephased because it's going faster. And what we are left with is more of the water spins, and that will give us a signal. So a long TE will give water-based, a T2-based image, and a short TR will give a fat-based image. So it's just an animation of what I've been talking so far. So all spin echo sequence will have a 90-degree pulse followed by a 180-degree pulse. Both these pulses have to be present to call it a spin echo sequence. I can see in the animation there, initially it was straight and along the longitudinal plane, and then it was flipped into the transverse plane, and it dephases. Then you give a 180-degree pulse and rephase it back, and then you receive the echo. So gradient echo is a more advanced version. Like initially in the early 90s or 80s, there was only spin echo, then gradient echo came in the 90s. So what we do here is, instead of giving the 180-degree pulse, we give another gradient. So what happens with the 180-degree pulse? We actually wait for the protons to dephase, right? And then we try to rephase it back. So that takes time. So instead of that, if we apply an external magnetic field and we make the protons to dephase and rephase, so we can quicken the time. We can do it at our will. If we use a higher magnetic field strength, higher gradient field strength, it'll dephase even quicker, and we can make it rephase faster as well. So basically what GRE does is that it changes you can see in the first image, the first 90-degree pulse, and the spin echo, the echo, we only reach it much later. But with the GRE, we compress it all down to that short interval. So GRE reduces about maybe 5 to 10-fold time that is taken by a spin echo image. And this is what finally we get. A shorter TR and a shorter TE will give more T1 weighting, and a longer TR and a longer TE will give a T2 weighted imaging. What do we get if we use a short TE and a long TR? We get a proton density image. So it doesn't show much of the contrast, but it has a lot more signal to noise ratio. But we don't use that in neuroimaging that much nowadays. And now we move on to the MRA part of the physics, the flow effects. So what we have, first is the flow void that we are very familiar with in a T2 weighted imaging. So what happens is that when we give the first 90-degree pulse, and we wait for some time before we give the second 180-degree pulse, right? So at that time, the moving spins inside the vessel would have moved from that particular slice. So when the 180-degree pulse comes, it no longer finds that the moving spins there. It is already further slides down the road. So what we are left with, there's no signal from there. So that's why there is a flow void in a T2 weighted image. This is a patient with AVM, and you can see clearly the large flow voids in it. But this is not the case in a gradient echo image. because we don't have a 180-degree pulse. So after the 90-degree pulse, we directly go on to the gradients, initially trying to dephase and rephase automatically. And this gradient is there all along the tube. So it's not just in one particular slice as that 180-degree pulse was. It is there the whole breadth of the patient. So even the protons move out of that particular slice, they will still be influenced by the gradient field, and they will give us a signal. So since we do receive signal this time, there will be flow enhancement rather than flow void. So this is what we end up getting. There is flow enhancement in a gradient echo image and a flow void in a spin echo image. So now let's construct an MR angiogram. So what do we need? We need to increase the signal from the flowing spins, and we need to decrease signal from the stationary spins or the background signal. So how do we increase the flow signal? As I just mentioned, we use a gradient echo, not a spin echo. And we use a short TE. Why do we use short TE? Like in a short TE, there's more signal. The more time we wait, they dephase out. So in MR, we are not concerned about the contrast between T1 and T2. We are only concerned about the signal that's coming off the moving spins. So we use a shorter TE. And higher the field strength, better the signal to noise ratio. And how do we reduce the background signal? So let's use a 90-degree pulse. And immediately, instead of a 180-degree pulse, if we send in another 90-degree pulse, only the small longitudinal relaxation will be flipped. So if we repeat it multiple times, the longitudinal relaxation will be fewer and fewer, which means that it has no more longitudinal relaxation at one point to send, to create signals. So that's what we call a steady state, and that's what we want for the background signal. So background noise, background tissue, signal from the tissue will be suppressed. So the flowing spin will stand out. And we can also use things like fat suppression to further cancel out any other signals that's remaining. So this is what we finally get with. So you have two slabs. That's when, before the RF pulse goes in. When the second pulse goes in, both reduces. But because of the moving spin has full longitudinal relaxation, unlike the stationary spin, which have been reduced by the repetitive RF pulses. So with multiple RF pulse, in the last image, we can see there is no more signal coming, or very minimal signal coming from the stationary spin, but the moving spins, because they're coming from a slice before, which does not have the RF pulse, they have more signal than the stationary spin. And this is how the image looks. And nowadays, like, we are moved away from the 2D. We can, just with any other sequence, we can do a 2D or 3D, just like with West wall imaging. But we are moved away from the 2D into 3D because 3D has a better signal to noise ratio and a better spatial resolution. But the problem with 3D is, once the moving spin enter this box of RF pulses, they will also get saturated, because once it's inside this box, there's no difference between that and the stationary spin. Both are being subjected to the same RF pulse which was initially bombarding them. Only the newer spins have the full longitudinal signal. So a compromise can be achieved by using this called MOTSA, which is multiple overlapping thin slice slab acquisition. So this is what we actually do every day in our MRA. So we make smaller slabs. It is still utilizing a 3D, but instead of covering the whole brain, we only cover a thicker slab, not the entire brain. So usually about 3 or 4 slabs will cover the whole brain. And each slab now acts like a 3D. And this is an image, a regular MRA image, but I windowed it enough. You can also do it in your console. When you go back, you can see the lines over there on the image on the right. So that those depict the different saturation bands, actually. Okay, so this MR sequence that we have created, it doesn't distinguish whether the signal comes from below up or up down. Any spin that comes outside this box into the box will create a signal. So venous signal from the superior sagittal sinus entering this box will also create a signal. To avoid that, we use another thing called a saturation band. We place it on top of our imaging field of interest, so that to cut off all the venous signal that comes from top down. But all the arterial signal going from below up doesn't have a saturation band, so that will be seen. And this is the final image that we are familiar with. So we move on to the more juicy bits. the clinical applications, or rather on the pitfall. So this is an MRF done in our department. We can see a signal in the superior sagittal sinus. So this should not be misinterpreted as a DAVF with flow signal in the vein. It is there in the arterial phase already. So this is a DAVF. No, that's not the case. If you analyze this image carefully, they have included this box all the way up to the vertex. As you can see, the superior sagittal sinus is seen. So the saturation band goes further on top of it. Basically, it's not doing any function. It is not canceling out the venous spins that is coming from the superior sagittal sinus. That's why you see the signal in the vein. This is just an artifact. This is another example where you can see the scalp outside the skull. So the saturation band was not even in the picture. So you have to see the venous signal. If you don't see it, that is abnormal. But you can see that the venous signal, the signal stops short. That's because when they were acquiring this slice near the corpus callosum, at that time the saturation band was on top of it. So there is no venous signal in the sinuses at that level. But when they went on to the next level, then the saturation band went further on top of the skull. So that's no longer working. And you get the venous signal only in that particular slab. And the second artifact I want to talk about is the breathing effects. Normally, when the flow in the vein is actually quite fascinating. We all imagine that arteries just flows away from the heart and the vein just goes towards the heart. That is true only during certain situations, like now when I'm standing. So the venous return to the heart and to the lungs, they depend on two factors. One is the respiration. So when we breathe in, the blood rushes into the lungs and to the right heart. And the second factor is gravity. So gravity aids in bringing the heart down from the head and the neck. But when the patient is lying down supine in an MR scanner, the gravity is nullified. So there's no help from the gravity. So all the movement happens predominantly by the breathing and the pressure from the artery pushing it out. But that's minimal. So what happens, like in some patients, maybe they are expiring a lot when the scan is acquired. So the flow actually reverses. So what I'm showing in this example is that, it's a shame that I don't have the pointer here, but you can see the two vertebral arteries and the two carotid arteries. That's the brighter signal. And just beneath the carotid artery is the jugular vein. So you also see some signal in the jugular vein. So that's not because it is coming from top down, but rather it's because it's going from the bottom up, just like in the direction of the arteries. And in the next image, you can see the transverse sinuses follow the IJV further up. The transverse sinuses, they also show the same signal. And if you focus carefully, just on either side of the basilar artery, you see two signals. So that's actually the inferior petrosal sinus. So when the blood goes from below up, it goes all the places into the sinuses as well. So that's how we should distinguish this from misinterpreting it as probably a DAVF, because we already see the venous signal in a MR angiogram. That this is just because of the respiratory effects, breathing artifacts. This is a classic case that we had it in our department. So there was some signal seen in the right cavernous sinus that you can see here. So this was raised the possibility of a CC fistula on the right side. In fact, the patient went on to have a angiogram. So on the right, you see the internal carotid artery injection, and the left, you see the external carotid artery injection. So you absolutely see no flow, no CC fistula. So the reason is, again, it's just a breathing artifact that came all the way up the IJV, the jugular bulb IJV, and into the cavernous sinus. So if you scroll the image down, you could actually appreciate the signal which was persistent at that level. And as a rule of thumb, we always look for other evidence, right? In this patient, there was no dilated superior ophthalmic vein. And we have to take into account all these things before we raise the possibility of CC fistula. This is another unique case that I came across many years back. You can see that in the midbrain, in the cerebral aqueduct, there is some high signal. So this is to further illustrate the fact that any moving spin would create a signal. It need not be just arterial. As we saw in the previous example, it could be in the veins. It could also not just be in the vein, it could be in the cerebral aqueduct. So this patient has a normal pressure hydrocephalus. As you know, there is hyperdynamic circulation. So in the cerebral aqueduct. So in the MRA, we see the flow signal just because of the hyperdynamic flow. And in the T2, we can see the flow void that we just discussed because it's a spin echo sequence. So the movement causes a flow void. And this is the sagittal reconstruction where you can see the midbrain region. There is this white signal that's because of the hyperdynamic flow. And on the right, you see is the MIP images. So it just happens so that the saturation, the slab just started at that level. That's why probably in this patient, there was this signal seen in the cerebral aqueduct. And it further goes up into the third ventricle and disappears, the jet. And this is a real example of a patient with CC fistula. So it's a direct CC fistula, so there is so much blood going across. So that's why you see both cavernous sinuses showing flow signal. And I'm coming down, you see the signal in the IPS. But further down, what happens? At the level of the jugular bulb or the sigmoid sinuses, you don't see the flow. So that's because even though there is a high flow happening, it gets diluted out when it comes to that level. So normally we may not even see the flow signal there. When we see that, we should seriously consider if it came from below up rather than from top down, like in a CC fistula. And this patient obviously had like much dilated superior ophthalmic vein. So we always look for all the supporting evidence as well. And this is a classical case of DAVF showing arterialized flow signal in the transverse sinus. Okay, the third artifact that I wanted to bring up is, as we saw when we made the pulse sequence, we used a short TE and we also used a short TR. So that is the same characteristic of a T1 weighted image. So which means that all gradient echo MRA images will also have T1 weighting. We all know that, but this is the physical explanation for that. So this patient was with liver cirrhosis, portal hypertension, portosystemic shunt happening, and there is manganese or other heavy mineral deposition in the basal ganglia. So this is the MRA sequence, but these T1 shortening effects will be visible. This is also called as T1 shine through, just like a T2 shine through. Why I brought this up is, look at this example. Well, maybe in the first glance, we might just look past it. It's just a regular MRA. But this patient actually had a dissection, intramural dissection with an intramural hematoma in the petrous segment of the ICA. So if you look again carefully, there is actually a dissection flap. But the blood on the other side of the dissection flap, since that is also going to cause T1 weighting, it's going to cause the same high signal. So we shouldn't be foxed by this. We have to look the axials as well, also look at the T2 for the flow voids before we conclude about the scan. All right, so another application of the thing what I just said is, this is a patient with aneurysm, a paraclinoid aneurysm that underwent a flow diverter treatment. So the way flow diverter works is, it's not like coiling. We are not closing off the aneurysm instantaneously. We put the flow diverter and we promote thrombosis inside the aneurysm so that it finally closes up. So, but in this patient, at the follow-up at 6 months, we still notice some high signal in the aneurysm. So we raise the possibility that it hasn't closed yet. And we had an angiogram, diagnostic cerebral angiogram, which again showed the clear aneurysm that is there. But look at this example. This patient also has a parophthalmic aneurysm, also underwent a flow diversion treatment. And in the follow-up, you see a little bit of a signal on the right parophthalmic artery, just medial to it. This was also raised the possibility of non-occlusion. But the angiogram, this is the intra-angiogram CT, IACT, where it doesn't show any flow there. So this is because when we are actually wanting to promote thrombosis in the aneurysm, right? That's how flow diverter work. So when the thrombosis happens, the thrombus is also going to be T1 hyperintense. And that's why it was showing that signal. So nowadays when I report, with such a thing, I give both differentials and leave it as such. So the interventionalists will then decide whether to investigate further or wait for some more time to promote the thrombosis and do the imaging later on. Okay, so the fourth and last but one clinical application I want to talk about is loss of flow signal. So now we just saw the GRE sequence, how it creates the flow signal and so on and so forth. But there is another concept known as intravoxel defacing. So I showed you the localization where there was gradients in different planes, x-axis, y-axis. So all of them, we are doing it to give a unique character to each voxel, or rather the protons in each voxel. So when there is turbulence, so they're going to mix up. In a laminar flow, they will, in this example on the top, it's a laminar flow. So the orange ones and the green ones and blue ones will always be separated as they move along the vessel. But on the bottom one, there is mixing up happening because of the turbulence. So then the spins will start to cancel out each other because they are in random orientation now. And we'll have loss of flow. So look at this example on the right. It's an MRA. At the Peters segment, we see the loss of flow signal. This is not an ICAD or it's not a dissection. It's just an artifact. The CTA done 1 day later shows there's no disease at that site. That's because of the turbulence. And what happens in this example? So obviously the MR was done first. If you focus on the left MCA, there you can see that it's completely flow void at the junction of the M1 and M2. So we already know that there is a severe stenosis. We are kind of tuned to it. But the reason why it happens is again the intravoxel defacing. So when there is stenosis, there is increase in velocity and turbulent flow. So that again mixes up the spin and gives us loss of signal. So this is the angiogram. This patient went on to have an angioplasty for that lesion there. That shows the hairline patency of that artery, which we can't see it in the MR. Unfortunately, we can't avoid this, but the most we can do is we can decrease the voxel size. So the intravoxel defacing is limited to a fewer voxels, and we can reduce, we can increase the signal at least from the artery just before or just after the stenosis. Okay, then the last effect is the saturation effect. Maybe you might have heard that the in-plane effects, like sometimes when you notice an artery, if it travels parallel, then you might see some loss in signal. So again, that is technically not correct because the loss in signal is not because it is parallel. The loss in signal is because it is spending more time in the Mozart slabs. So the spins, as once they enter the slab, they'll start to lose signal just like the stationary spins. So in a perpendicular artery, it spends less time in the slab, then it exits, new spins comes in. But if the artery is going parallel to it, it is simply spending more time in the slab because it's traveling along the gradients rather than across the gradients. So there will be loss of signal. And the image on the left is a 2D acquisition. It happens so that in that slice, the artery was parallel and there's complete loss of signal. But on the right is a 3D acquisition where there's only a little bit reduction in signal, but not complete loss. And if you further follow that, once it makes the bend, then you can see the signal comes back again. It is a stronger signal. That's because that is already the next Mozart slab, the one above. Okay, I have one last thing. This is not exactly the MRA, but the flow effects in the other MRI sequence like T1 and T2 and so on. So this is the image of a T1 spin echo sequence. Okay, by rule of thumb, spin echo sequence should show flow void, right? But T1 is an exception in a minor way because T1 also has a shorter TE and TR we just saw. So sometimes in the first slice, when the spin comes, it kind of gives the same effect as the gradient echo. So you might see some signal in the first slice, but in the second slice, it already will be defaced because of the gradients, because of the other RF pulses. So why I'm bringing this up is we should not misinterpret this as a vertebral dissection. These are the T2 images and the MRA, it was completely normal. So if you are looking for flow voids, it's better to look at T2 because T2 has a longer TE. So it is more robust. It will not have this flow effects, flow related enhancement, which T1 may have. Even T2 will suffer if the flow is really slow. So this is done at the level of the neck, where we see the bilateral jugular veins that are hyper intense on the T2, the image on the right, but the arteries are still black because they are having a higher flow rate. So the reason why I put this image is for doing an MRV, we do not rely on the TOF MRA anymore. we go on to do a phase contrast because the velocity is quite slow and the spins will start to get saturated and we will not get a good signal with the MR if you do a time of flight MRB. And I think this is my last slide. So what happens with the flare? Flare is also similar to T2. So when there is a slowing of flow, that will also start to show the signal in the vessel. So this patient came in with occlusion of his M1. He actually had a duplicated M1. So there's the smaller M1 is still patent, but the larger M1 has a clot and there's no perfusion happening on the right cerebral hemisphere. But when you look at the flare image, concentrate on the parietal region, you see a curvilinear hyperintense structure. So that's actually the distal MCA. And that is showing signal because there is the flow there is approaching stasis or it's like very slow flow. Flare accentuates it better because CSF signal is suppressed. The same effect would happen in T2 as well, but because CSF is already bright, we can't appreciate it that well. So this gives us some opportunity where if you see a really tight stenosis and want to decide whether it's causing a hemodynamic infarct, should I go on angioplasty or stent it, you can also make use of the flare and look for these signal in the vessels, and that will tell that there is underperfusion in that cerebral hemisphere. And this is a described sign. It's called the IV sign because it resembles the IV plant creeping up along the stone walls. So that's why it's called an IV sign. All right, so that's my 2 cents worth of MR physics or MRA physics, and these are my acknowledgements. This book, MR Made Easy, it's really easy to read, literally, and it's very useful. And there's also an MRI course by Dr. Michael Lipton from Albert Einstein Medical University in New York. The good thing is this course is available on YouTube for free, and it's a really good source of information on MR physics. Thank you for your attention.